Yeah, thank you, sir, for the kind invitation. I thank all the members present here. I'll be
Can
talking
you be
about.
louder because your voice is quite feeble?
Oh, really? Okay. Yeah. So I hope you can hear me now.
Better,
I'll
yeah.
be talking about intravitreal drug therapy. There is a lot to discuss, but I will discuss the main points, and then later on we can take up the guidelines by email with all the esteemed members in this panel. The key studies which I will cover, just to highlight the top lines, are protocol I-T, which compared the different anti-VEGF agents, MEAD study for Dex implant, and also protocol V when the vision is good, but there is center involving DME. The protocol I looked at.
Increase the voice, please.
Sorry, you are not able to hear me still? Okay, so protocol I looked at ranibizumab with deferred laser or prompt laser, and overall what it showed that at the end of 1 year or even at 5 years, there was about 10 letters gain in vision, or that is 2 lines of gain in vision. But what it showed was that patients who have less than 20/50 vision, that is about 6/12 to 6/18 vision at baseline, who had less than 6/12 or 6/18 vision had a much better vision. Let me just switch off my video. I think my internet is slow. So yeah, so overall the vision was improved by about 15 letters if the patients had worse than 20/50 vision. So that was a main thing which we have to understand. Worse the vision at baseline, more is the improvement. Protocol T looked at bevacizumab, ranibizumab, and aflibercept comparison. What it showed was overall in the patients who were less than 20/50 vision, as I showed in the previous slide, patients had good improvement, and the maximum improvement was with Eylea or aflibercept, almost 20 letters, that is 4 lines gain in vision. So patients who have baseline vision is bad, they improve more. That's a theme which you will find all throughout different studies. Better vision at baseline, less will be the improvement. More the worse is the vision at baseline, more will be the improvement. So this slide again shows patients who have better than 6/12 vision, they have about 7 to 10 letters gain in vision, irrespective of whether you give Avastin, Lucentis, or Eylea. So that's the thing which we all keep in mind. But that patients who have good vision at baseline, even Avastin may be a good choice. And what this slide shows is that aflibercept has the greatest reduction in thickness, and bevacizumab or Avastin had the least reduction in thickness. What about this number of injections? How often do we follow up? That's the more critical question. Why we all understand and tell patients vision may not improve completely. How often should we call them? How often should we inject them? When should we re-inject? So in protocol T, they called the patients every 4 weeks. They differentiate 4 weeks and 1 month. They are very specific about 4 weeks. And then in the second year, the patients were called every 4 to 16 weeks, depending on the condition of the patient. But at 6 months or later, the patients were also advised focal or grid laser if the DME persisted. What were the retreatment criteria? They are very strict for the first 6 months. You keep on injecting unless there is success. Success means either 6/6 vision or 20/20, or there is no edema. But till then, in the first 6 months, keep on injecting. Beyond the first 6 months, they understood that patients may not always get 6/6 or flat retina. So they said that if there is worsening by 5 letters, then you re-inject. But if there is no worsening in the last 2 visits, vision is stable, you may not inject. Or if the OCT worsens by 10% or more, you again re-inject, but the OCT is stable. Even if there is edema, the vision is stable, OCT is stable, you may not re-inject. But beyond 1 year, they had a failure criteria. They said, okay, I will not inject, or I will switch to steroids. That is only after 1 year. But that's something which our patients can well afford. So what happened in protocol T? 15 injections in 2 years. We all know this is not realistic probably. So we have this another option, dexamethasone implant. We also have IVTA protocol. I did look at IVTA. There were glaucoma issues, cataract issues. So if patients don't have glaucoma or they're pseudophakic, you may still consider IVTA in some of these patients. But what MEAD study showed was that patients, if you can see these top graphs, the patients who were pseudophakic did very well. But phakic patients started reducing, had less vision even after the injections. So with this, the number of injections of Dex implant was only about 4 injections in 3 years, which was not bad compared to when we see protocol T 15 injections. So when would you switch in real world, less than 5 letter gain, less than 10% reduction in thickness? These two are called functional failure or anatomical failure. And what does the VRSI survey show for a non-responsive DME? Most of the members switched by the third injection. We would never wait for 6 injections to switch. So by 3 injections, if you don't find improvement, we will switch to steroids most often and not to switch to some other agent. This is a graph showing whether they will change to another anti-VEGF. Most of us would switch to steroid instead of another anti-VEGF. And steroid at baseline at first visit was only considered if the patient had any heart attack or stroke and the patient was pseudophakic. Otherwise, patient members would still inject anti-VEGF. What about patients with good vision at baseline but with center involving DME? Protocol we showed that whether you give injection or you do laser or you observe, there was no difference in the overall outcomes. But it's an individual physician discretion. If the patient complains of metamorphopsia, you may still go ahead and inject these patients. What about the Indian guidelines published in IJO? Anti-VEGF is recommended the first line of treatment, laser for non-central DME, and if there is central DME with good vision, we still recommend laser. Surgery for VMT ERM is recommended, and end point is that if there is no change in vision or less than 50 microns in 2 consecutive visits, then you may consider just observing these patients. One last point I would like to show here, because these are guidelines which we have to work on. We want to make sure that people who inject actually are trained in injections. This is a cataract surgeon who is giving intravitreal OZX injection. Unfortunately, the cataract surgeon has not been trained in giving intravitreal injections. This injection goes and hits the lens, and the injection also is done inside the lens. And ultimately, during cataract surgery, this comes into the AC, and the OZX injection also gets emulsified during surgery. So, a key point which SAO must consider when recommending guidelines is that we should tell that every ophthalmologist should get trained if they want to treat DME. So in conclusion, DME generally start with anti-VEGF, switch in 2 to 3 injections. Steroids can be used for maintenance. Surgery, although can be considered, you still start off with injections. Even if there is VMT, ARM, and DME, you may still get an improvement. And edema is the most important simple determinant for decision making. We are not going into OCT biomarkers at this time. But thank you very much for your kind attention. That was my last slide. Thank you very much.
Thank you, Raja, for a lovely presentation. Very brief and to the point. Uh, Only one question: if the patient is doing well, can you give steroids for maintenance, just to increase the duration?
Yeah, in the sense if the patient is
Phakic eye.
doing well, yeah, you can give definitely steroids, preferably Dex implant, because IVTA has serious issues of glaucoma, even if we are giving the preservative free one.